The Dravet population and the families that I've met, even in the short time that I've done neurology, have certainly made an impact on my life. A lot of the families that I've met in the ICU, particularly when they've come in after being in status, have really changed the way I think about a lot of the care for our patients. Luckily, as things have changed with some of the new drugs that are on the market, I'm actually meeting less and less families on a regular basis that have Dravet syndrome, which is a good thing, because I think I used to know almost all of them when I was a resident. So I think that's been a pretty big improvement. I don't really have any disclosures. I'm going to talk mostly about status epilepticus and the treatment for status. I'm going to talk a little bit about obtundation or non-convulsive status, and I'll explain all these things, although many of you probably already know a fair amount about them. And then some of the advanced and novel treatments that we have coming online. So really, what is status epilepticus? So first, it's important, obviously, to think about what a seizure is, although it's not always clear, even to a neurologist or an epileptologist, when someone's having a seizure, but it's a transient occurrence or signs and symptoms of abnormal excessive brain activity, basically. There's generally a clear start and stop to those things. Turns out that's not always true, and there's not always a clear stop and start. And so when we think about status epilepticus, or a seizure that's lasted too long, in essence, it's when the protective mechanisms that are inside your brain that normally would make a seizure stop on its own aren't working. Most of the time, seizures will stop, but if some of those mechanisms aren't working or your brain's just different, you tend to have longer seizures. And so part of the difficulty for me and for families is that we don't really know the answers to a lot of these questions. Just simply, when does the seizure start? That's always difficult, right? You're not always in the room when it started. You don't really know. And then we think at some point it's probably gone on too long and you're going to give a treatment. Then another time point in the future, we think it's probably gone on way too long and you really have to do more than that. And then we don't even know the last question of when does that actually cause damage to the brain. I get asked that question and I fail to answer it many, many times. Has this hurt my kid? And if they're going to have more, is it going to hurt my kid? And we don't even know that. So all of this in the end then is practically not very helpful. So what data do we have about much of this? So although it doesn't show up really well, I don't know if is there a laser pointer on here? I think maybe. Oh, nice. So this data over here is trying to show in an epilepsy monitoring unit for patients that have refractory seizures that obviously went into a unit to get monitored, how long the generalized tonic-clonic component of their seizure lasted. And what they found in that study is that most of the time, the generalized tonic-clonic seizures stop by 120 seconds. And so that's what you'll hear a lot of doctors, including myself, say, is that most seizures on their own will stop within 1 to 2 minutes. Well, that's kind of true, except if you study kids or know any kids that have seizures, is that many of them last way longer than that, particularly for kids that have never had a seizure before. They tend to actually have seizures that last way longer. So all the way over here on the end, maybe if I use my mouse, let's see. Does that work? There we go. So this is time down here, and these are actually minutes rather than seconds. This is almost a logarithmic scale, though, so this is the proportion of kids that basically their seizure has stopped. And so the majority of kids, so this is like 30%, have had their seizures stop by 10 minutes. So although probably in kids most seizures do stop on their own within 5 to 10 minutes, if it's lasted longer than that, that's where it becomes really atypical. We generally want them to stop sooner than that, but we may not be successful. So it's not strange that seizures last longer than that, particularly in the Dravet population. How common is status epilepticus, or a seizure that's too long in Dravet? There's not perfect data on this either, but at least in a couple studies I could find, 94% of patients, and it may be even higher than that depending on how they defined it, of kids with Dravet will have had status epilepticus, and most of the time that happens before the age of 9 months. That's how usually most kids come to care initially, is they have a long seizure associated with a fever, vaccination, things like that, and then they come in with a very long seizure and meet a lot of doctors, and then it's over the time course we figure out what they have. Most patients with Dravet syndrome will have more than one episode of status epilepticus, somewhere around 90%, compared to other kids that have had status epilepticus for another reason. About 40% of them will have another episode. So it's way more common, as most of you know, in Dravet to have multiple episodes of status. So that's just the background. So what should we do at home? What should we do at home if we think that someone's going to have a seizure and it's going to last a long time? And so I think of it as mostly that primary prevention is trying to make sure that they don't go into status. So daily seizure medications, trying to make sure that you don't miss them. I know that I probably give my kids 12 days of antibiotics every time they have an ear infection because I forget, and that's just 10 days. And so it's really hard to do. I just gave an example here because there's a recent study on it for stiripentol. They found that 40% of patients that were on stiripentol had a greater than 50% reduction of status epilepticus, and 26% were actually status-free. And those were the kids that in the 3 months prior to starting the medication had status epilepticus, so not just all of the kids that were in that study. And so that's a pretty big difference, and that mirrors our experience here using stiripentol, that many of those kids have a reduction in the amount of time that they come in status and come to the ED or the PICU or using rescue medications. So if you can prevent it, that's way better than me fixing it. The next best thing you can do is have an emergency plan, so know what to do if the kid's gonna have a longer seizure. So, a lot of these are recommendations from a consensus group from working with kids that have Dravet. And so all patients should really have a home rescue plan. And then a lot of times what you need is not just that home rescue plan, but what are you gonna do when you show up in an ER? And depending on where a family lives or where you live, if your ER isn't comfortable or doesn't know how to take care of kids with seizures, because we certainly see that a lot for families that live farther out in the community and aren't going to a children's hospital, making sure that that local hospital knows what to do and having a plan that you can work out with your doctor and you can communicate with them is going to be much better, so that you're both comfortable if your kid has a long seizure and needs to go to the ER, that they know exactly what to do when you get there. So sometimes we'll write an emergency seizure plan for home, and then we'll laminate something and send it to the ER so that they have it on file and know who to call, and we can update that as time goes on. So when should you give an emergency seizure medication? You know, the default guidance is usually if a seizure's lasted more than 5 minutes, but in reality, it really depends on your kid. So in general, not just for Dravet syndrome, does your kid always have long seizures? If they always last 7 minutes, giving a medicine at 5 minutes doesn't make a lot of sense if they're only gonna last 2 minutes longer. And does your kid always go into status? Do they always have long seizures that always need to be treated, that you're always going to the ER for? In which case, you're not going to want to wait as long. And so at a minimum, you should probably think about giving an emergency medicine unless they always have long seizures for within 3 to 5 minutes, especially if it's convulsive. And then generally, if they always go into status, I would say give it as soon as you possibly can. You can, and this always has to be worked out with your specific physician, so it's general advice, but you can frequently give a second medication or second dose if the first one has failed. And then there's a general recommendation that if you're having a cluster of seizures, that giving a medication in that setting can be beneficial. But all that depends on each individual patient and what they're like. Trying to give out blanket advice is always really difficult. So what should you give? A lot of times what we're using is rectal diazepam. We can also use intranasal or buccal, kind of in the cheek, midazolam. And as you get older, it's more and more embarrassing or more difficult based on your size to give a rectal medication. And so it can be easier to give the intranasal midazolam or buccal midazolam. For some kids, we've even done intramuscular phenytoin or fosphenytoin for kids that haven't responded to these other treatments. I'll talk a little bit about diazepam and intranasal midazolam in a second in terms of cost effectiveness. One of the things we want to highlight is we would avoid medications that are coated in oil, because if you aspirate that during a seizure, and particularly a convulsive seizure, you can get a lipophilic pneumonia and a bad pneumonitis. And so that's one of the things that we always worry about. And with a lot of the cannabinoid, especially the homemade cannabinoid or custom cannabinoid solutions being made in lipophilic solutions or oily solutions, we worry that that could make a bad pneumonia happen. So in terms of Diastat or rectal diazepam or intranasal midazolam, there's actually been some studies that have looked at how effective these drugs are. And I think one of the most important things that I found when looking at this literature when it was first coming out is that intranasal midazolam generally could stop seizures faster. And let's see if I can find it on here. It's hard to see on the screen. But if you look at that median total hospital charges, so if you gave intranasal midazolam, it was like $1,500, and Diastat was close to $6,000, I think. And so there's a huge difference in terms of number of kids that will have seizures when they show up in the ER again, number of kids will end up going into the PICU. And so we do think that there's probably a benefit to sometimes using intranasal midazolam. Additionally, the cost of the actual drug is way lower. And so for families that are paying out of pocket or can't get access to Diastat, which is up to $300 a vial, intranasal midazolam can be much cheaper. You have to be careful because the dosing can be a little bit more difficult with intranasal midazolam. So for small kids, it can be more difficult to give a half dose out of the syringe as opposed to a pre-dialed dose for diastat. And then a lot also has to deal with what the school is comfortable giving. So what should the emergency room do? They should do whatever they're comfortable with in the end, because you don't want them using a drug that they're uncomfortable with. But a lot of things that we would think about are, have they been able to get IV access? So if they can't, there are intramuscular medications that we could use, fosphenytoin, midazolam, and they could use rectal diazepam if that's what they have. Getting something into a kid that's seizing is better than nothing, and so those are a lot of the options that we have. If they do have IV access, we can use fosphenytoin, valproic acid, midazolam, Keppra, really anything that they have available. And then there's some next-line agents that we think about. Most of them end up being infusions, but midazolam or phenobarbital, there's sometimes, especially if you're ending up in an adult and pediatric hospital that's combined, they'll use propofol frequently, and that will basically stop the seizures. And then newer will be lacosamide or Vimpat, be another medication you've heard of. And then if they're still seizing at that point, they probably need to be transferred to a higher level of care. I get this question a lot, and I'm sure a lot of families ask about this. Sodium channel agents in Dravet syndrome are, I'd say, relatively controversial, but our experience is that it's mostly the chronic use of these agents that lead to adverse outcomes, that they've been associated with poor cognitive outcomes in kids. But acutely, if a kid's having status epilepticus, they generally tend to be effective. That's not always the case, but it isn't a medicine that I shy away from when I have a kid that I even know has Dravet syndrome that's having a long seizure, partly because it's fast, I can get it in, and in our experience, it tends to frequently work. And so I would rather get a medicine in rather than say, let's not do that and use a medicine that's going to be more sedating and have more risks with it if it's the one that's available. So what do we think about if you've gotten out of the ER and now you're in an intensive care unit? We would think about medicines like midazolam or more phenobarbital, Depakote. You can end up on a pentobarbital in a coma sometimes. And then some of the newer medicines, I'll talk a little bit about this, would be ketamine and lacosamide. A lot of kids with Dravet in particular generally only have clinical seizures, and so a lot of times you won't need the EEG, but if your kid's not waking up or your patient's not waking up enough that you can tell the answer to that question, then a lot of times kids will end up on an EEG to answer that question if they're still having seizures. And then obviously trying to treat fevers with ibuprofen, acetaminophen, and then sometimes cooling blankets can be necessary to help reduce that risk. Besides all of the medications that I have in my toolbox, which I hope to never have to give any of your kids or your patients, we think about the other strategies just to reduce the triggers. So napping if tired, overexerted, avoiding high temperature changes, using Tylenol or Advil prior to vaccination, depending on your age. And then the main things that I would say not to do would be ice baths or alcohol baths. Although those can cool you down, they certainly can be dangerous, especially if your kid's actively seizing. Getting into a bath and more water is a dangerous place to be. And so the other part of it is that patients may require more than one dose of emergency seizure medicines, but it's really important to work that out with your physician in the ER, because overdosing can be dangerous, but also can cause you to be resistant to some of these medications. I would avoid, I didn't write that, avoiding. It should be avoiding immunizations is something I would not do, because most of the things that you're trying to avoid will make you sicker, and we believe that it still provides benefit. And then obviously suddenly withdrawing any of the anti-seizure medications that you're on can certainly put you into status. So that's enough about status. I'm going to move very quickly into non-convulsive status. So this is something we don't actually know enough about. So kids with Dravet can present as teenagers or older or school-age kids with seizures that are a little bit more discrete. So they're not just convulsive seizures. They can be a change in behavior. A lot of times they're associated with just this fluctuating mental status, that they just don't seem like their normal self. They might be having more myoclonic events, more picking at things. They can be just kind of slumped over a little bit more than they usually are. And that's probably the best description I've been able to find across all the papers that I read. So if you're concerned that your kid's not doing what they're supposed to be doing, and you may not have actually seen them have a seizure, then it's very appropriate to call your doctor or bring them into ER and have a discussion. Unfortunately, probably the best way that we can try to answer this question is with an EEG, and that still may not be convincing, because a lot of times the EEG isn't the classic type of EEG that we would see with a seizure, but that's the best thing that we can do. And then sometimes that means that we're going to try empiric treatment. So at home, if your kid's done this before and you know that something will work, trying an emergency seizure medicine, calling and talking with the neurologist or someone that's on call. And then when you go to the ER, an EEG can help answer that question if you've had a recent baseline EEG that would tell us what it looks like when you're doing well. And then trialing doses of medications to see how it affects the EEG and if the child kind of starts to wake up and act more like their normal self. So what are the advances? Sorry, that slide came up a little weird. So those are all the different places that we target in order to treat seizures. There's a lot of different drugs on there. And there's not really a great way of saying that any one of these is going to be the next thing, but different combinations of drugs and for different patients may be the answer. One of the newer drugs that's on the market is ketamine. We use it more in the hospital. It's not really available. It is an easy outpatient medication. The benefits we see in the hospital are that it doesn't tend to be sedating as much in terms of needing a breathing tube. It doesn't take away your respiratory drive. And it can be used in combination with some of the other medicines we have. The other benefit is that it probably helps make benzodiazepines, so the Ativan, midazolam, medicines like that, more effective in that setting. And so that's one of the reasons why we've started using it. So if you hear about it, it is something that's being used in the hospital more. I think the next things that we need to start thinking about are how do we better understand the EEG pattern for kids that come in with this obtundation status? Can we better classify them or characterize them? And then are there specific medications that may be more effective for treating that than our traditional medications? I think also it will be important to better understand for Dravet and other genetic epilepsies, are there specific treatments that we could target? Can we start answering this question as someone would be more likely to respond to a sodium channel agent? There's lots of reports coming out of kids that would respond, or with Dravet, responding to things that we typically wouldn't have tried in the past. And then can we start to predict which kids with Dravet, based on early EEGs were usually normal, what their prognosis is going to be and how can we better effectively treat them? And I know we're going to do questions with the panel, but that was my typical ending slide. So.